She is a cataract and cornea surgeon, and along with that, she is also currently the editor of IJO, which is one of the biggest journals in ophthalmology right now. She's going to speak to us about specular microscopy essentials. Over to you, ma'am.
Yeah. Thank you so much. I think I'll keep my talk for about 10 minutes or so, and I will tell you more about this, the practical aspects which you would need to know as a postgraduate or as a fellow when you are examining the cornea. Have no financial interest in the mention of anything during the course of my talk here. When you look at I also wish to acknowledge Dr. Kusumita, my senior resident, who has helped in with the academic inputs for this presentation here. So when you look at specular microscopy, it is one of the basic methods of corneal imaging on corneal examination here. It helps you to look at the various layers of the cornea. So you have almost 5 layers described here. I'm not going to run you through the corneal anatomy here. It's self-descriptive with this picture here. And it is one of the earliest methods of examination which went way back by Vogt till 1920. Morris refined it in 1968, and what we now have is the specular microscopy for visualization, which we largely use for the endothelial cells of the cornea here. And the endothelial cells are a monolayer of polyhexagonal mosaic pattern, and each cell is about 20 microns with a surface area of 100 to 250 micrometer squares and a thickness of about 5 to 6 microns. And at birth, we all have something close to 4 lakh of endothelial cells in our eyes, each of our eyes here. And this develops in the 4th week of intrauterine life, and the FOXC1, PTEX2, PAX6 transcription factors are elucidated, and that's why any of the genetic anomalies which define these are going to be affecting the endothelium here. And looking at the microanatomy and the biochemistry of the endothelial cells, you have leaky junctions, endothelial cells connected by tight junctions at the apical sides. This is just for you to understand that the junctions which are there adjacent side to side, the apical region, the basal region, they are all different, and hence it makes it one of the most metabolically active layer in the body here. It has the sodium potassium ATPase pump and the Mg ATPase pumps as well. And I think I will not go more into it, and I will recommend that you all go back and revise your gross anatomy, your microanatomies, your biochemistry and pharmacological basics of the endothelium here. So this is how you can look at the endothelium when you're doing research here, but by and large, most of us will probably understand these 2 figures here. And what I'm going to talk to you is how you would recognize the endothelial abnormalities based on these examinations. The optics of a specular microscope is a class by itself here. To just talk about it in the next few seconds is when there is an incident ray of light which is reflected perpendicularly. It then captures the abnormalities at a microscopic level here. So I won't go into the depths, and I would again ask you to refer to your textbooks on how you would, on the basics of optics, because this is something which is asked in your short notes and which is asked in your instrument vivas and your fellowship exams as well. So when you look at a specular microscope on high magnification, this is how you would be able to pick up your endothelial cell abnormalities. The subtle ones, an experienced eye can pick up, but then those which have the largely visible or abundant guttate changes, which is classically described as a molten metal beaten appearance here. It's something like when you have hammered a molten metal, where you would have those fine depressions. That's the kind of the picture, and this I think none of you would miss when you examine or do a routine slit lamp examination under a higher magnification here. What instrument do we use to look at? We use the specular microscope here. So I have largely limited my talk to specular microscopy and not you included confocal in this here because of lack of time, and we have several models here, and depends upon what you would want to look at. But what you need to know as a resident or fellow is there are several types. You can do a contact, you can do a non-contact, you have a stationary slit, you have a moving slit here. And of course, you have the confocal based and the non-confocal based imaging modalities for specular reflection here. Again, a word of caution is what you look at at a routine slit lamp examination is not specular reflection. It is very difficult to do a specular reflection. You will have to know how you need to seat yourself here, how you would have to place your illuminating piece and your main piece, and you'll have to move it across 30 degrees here and in an oblique angulation. So that again is another learning methodology, and you'll probably need a hands-on before you would understand the specular reflection method. And I would say I will have to acknowledge it's usually a very difficult methodology of looking at your endothelial cells by a specular reflection methods here. And if you have difficulty in capturing, I think you need a smooth surface. Just see that your tear film is adequate before you go to image here. And now most of these specular microscopes have an automated inbuilt software here, which helps you to compute or understand what are the abnormalities or what is the health of the endothelium that you are looking at here. So this is one such picture of one of our specular microscopes here. And whenever you're looking at an endothelium, when you're looking at it, I always tell my residents, look at it in two aspects. You do a qualitative examination and a quantitative examination here. So these are the two analyses which you need to do when you're looking at your endothelial cells. So when you look at the quality, you look at the cell borders, the configuration, the intersections, the presence or absence of guttae or other extraneous ones like vacuoles, blebs, or other bodies which are present. Largely, remember, they are quasi-hexagonal shaped cells, and they appear as bright cells with dark borders. Again, this is important because when you look at the epithelium, again, you can use specular reflection to look at the epithelium also, but by and large, we don't do it here. And the epithelium will be an inverse of this, and it will be much smaller in size because the number of epithelial cells are much more here. So that's the basic difference which you will need to understand here. And here when you look at a picture, here it is self-descriptory. You see all the cells are not uniformly shaped here. They're not uniformly sized. There is a variation, and you're also finding a lot of dropout areas here, the blackout areas here, which means the endothelial cells are abnormal. They are not, there is a fallout here. They're not being imaged on specular reflection here, and these will constitute the guttae here. And this, the software itself images and then will tell you what is the number of cells which is being imaged per millimeter square here. It tells you what is polymegathism, which means what percentage of the cells are varying in size. Polymegathism, how many of cells are larger here, and pleomorphism, variation in size. So the variation in size and the variation in shape are picked up by the imaging, and that's what you would look at when you're doing a qualitative analysis of the endothelial cells. So these pictures are all self-descriptive, where you can see in different stages of the endothelial abnormality, you see how the cells are all, some are small, some are large, have lost their uniformity, some are six-sided, some have become four-sided, or some have become more than six-sided here. And here you're seeing the image capture is becoming more difficult as you go on, and here you're seeing a guttae which has started to form here. So all these are the pictorial imagings when you pick up on which you can pick up on your specular microscope to look at the anomalies of the speculum here. When you look at pleomorphism, that is variation in cell size, normally about 70 to 80% of the cells will be uniformly sized here. So it's not all 100% is going to be uniformly sized even in a healthy eye, but when this number drops down to less than 60%, it's going to be considered as an early abnormality of the endothelium which is going to set in. That's what you need to remember, that you will look at the percentage of hexagonality. So that's the first thing which you would probably look at your qualitative analysis, and you pick out here. Again, these pictures are self-explanatory. You're seeing the various types of guttae you're seeing here, and the classification of guttae. I think this is usually asked in vivas here. The stages of guttae here. When stage 1 is it's a small nodule and a small, just involves the center part of the smell. And when a gutta becomes larger, it becomes grade 2 when it is up to the size of an endothelial cells here. When several cells coalesce, then it becomes a stage 3 here, and multiple very large coalesced cells and much larger, then it becomes a stage 4 of a guttata here. This is again a very common question which old-time examiners would ask you is what are the frame of analysis here? So we would know about a fixed frame or a variable frame here. A fixed frame means your specular microscope fixes a particular area here, and all the cells within that fixed frame are counted for taking your automatic analysis in the software here. And when you do count, the cells are counted on 2 adjacent borders, and the cells falling on the 2 other adjacent borders are not counted here. So that's a fixed frame analysis for you. A variable frame analysis, you could count the entire cells present in a particular frame here. So that's a variable frame analysis which you have here. And when you look at specular microscopes, there are 2 types. You have a clinical specular microscope for imaging the human eyes when you are looking at your patients here, and you have specular microscopes for eye bank use or eye bank specular microscopes here. They are a little different because you are going to look at a cornea which has been removed from the human body, a cadaveric cornea which is usually now mounted on your bottle here, and you have special mounting systems and mirror systems which help you to analyze the endothelium present here. So there's a particular viewing chamber in the microscope here. So this is a specular microscope based on an eye bank, and this is a very important investigation because based on which you're probably going to grade your donor corneas as to an optical grade or a non-optical grade. Normally you would want your cells to be over 3000 when you're looking at an optical grade cornea, and cells lesser than 3000 will be considered as a non-optical grade cornea here. Again, a few clinical examples of a normal healthy endothelium and how a pathogenic epithelium is going to look at here. So among clinical applications, you will recognize early endothelial disease here. When you're operating, taking up patients for cataract surgery, depending upon the endothelial cell counts on a decompromised cornea, on a decompromised endothelium, you will plan, or your management decisions for intervention will differ whether you would want to do only a cataract surgery, whether you wanted to combine it in the same sitting with an endothelial transplant, the type of endothelial transplant you would like to do, or would you like to do a sequential endothelial transplant here. The indication or contraindication for placing anterior chamber IOLs in these sites. So these are all the multiple management decisions which the number of stability, the quantitative analysis will help you to give on these patients. You can pick up diseases like the Fuchs endothelial dystrophy, posterior polymorphous dystrophy, bullous keratopathies, and iridoendothelial syndrome. I quickly show you pictures of those as well. And it's also used for research and monitoring, as in age-related changes, post-surgical endothelial attritions for these patients, and other endothelial attritions because of other comorbidities like glaucoma, uveitis, corneal trauma, contact lens use, comparison between endothelial surgeries, and for endothelial cell culture imaging as well. Just a picture to look at how how endothelial cells in a young eye is going to look at, and what happens as you go. You could see that the sizes of the cells there's a polymegathism which you're seeing in this, which is an age-related change which you can see in this. Here you can see the slit lamp is showing a largely compromised endothelium here, and you can see the imaging is not able to capture any cells at well. Again, another picture of a Fuchs endothelial dystrophy with an advanced. The cornea is looking clear, but when you look at your endothelium, you see your image capture is not optimal here, and so these are going to be corneas. When you take them for cataract surgery, you will have to be wary that your cataract surgery needs to be uneventful and least atraumatic to the endothelium if you would want to save the health of the endothelium. Posterior polymorphous dystrophies again will also help you and will give you imaging like this. Iridocorneal endothelial syndromes again will help you to pick up them, because you would probably miss an early ICE, and this would help you to document the progressive change. And these cells also become more and more like epithelium-like cells rather than become endothelial-like cells as they progress on here. Pseudophakic bullous keratopathies, this is corneal endothelial decompensation because of cataract surgery and iatrogenic damage, and the amount of damage and how you would need to intervene and manage them in subsequently is another important. This is one of my DSEC patients, and it's a bilateral Fuchs here. She just recently underwent her endothelial transplant in the left eye, and this is an ultra-thin DSEC. It's about 6 years post-op, and this is how her endothelium is looking like. Just operated her last week here. Just to conclude and just to tell you about how the normal endothelial cell attrition happens here. When you're born with about 6,000 millimeters square, and by second year it drops to 4,000 cells per millimeter square, and it keeps decreasing by the year. So the normal endothelial attrition rates in the absence of any other abnormalities is going to be about 0.6% per year. So by the time you reach your 8th decade of life, you'll have something like 2,300 cells or so. Again, there is a change in the endothelial cell attrition rates, which undergoes a rapid attrition and a slow attrition. The rapid attrition happens in the initial years of life, and subsequently you go on into a slow attrition. The same occurs following several other procedures here. So this is in a nutshell, and this is a common viva question, which is again asked, that what is the amount of endothelial cell loss which you have because of the various procedures following FACO. Is about 5 to 8%. ECC is about 4.5% or a little more than that. ICC was used to give us about close to 50% drop if it's a badly done surgery. PKP, D6, DALS, DMAX again, and even following posterior PPVs and trabeculectomy. So the range again varies, and this is not a hard and fast rule. And these are what has been documented by large centric studies here. Advantages of specular microscopy: you would be able to image and get a qualitative and quantitative analysis, a pictorial depiction which you can record. But remember, it is not repeatable, meaning that you probably will not be sure you're looking at the same area again and again here. So there might be a mild variation in the area you're imaging here. So that's a particular disadvantage when you're looking at imaging using specular microscope. And it again looks at a very small area. So you probably will have to move your specular microscopes to, if you want to image the paracentral or the peripheral corneas. And imaging these is not usually very easy when if you're using a specular microscope. I would refer you on to this wonderful article in the Indian Journal of Ophthalmology for further reading here, and any other book chapter, including this, which is ours, which also talks to you about specular microscopy in further detail. Here I wish to acknowledge again my senior resident who helped me to put in the academic inputs for this, and thank you for your patience.